Welcome back to Scale Up Your Practice, the podcast from Obesity Canada. I'm Dr. Roshan Abraham, family physician and associate professor at the University of Alberta.
And I'm Michelle McMillan, a lived experience advocate with Obesity Canada. This podcast is where we bring together research, clinical expertise, and lived experience to explore how obesity care can be more compassionate and evidence-based.
Today's episode is supported by an unrestricted educational grant from Eli Lilly Canada. When we talk about obesity, we often jump right to physiology, movement, nutrition, medications, or metabolic markers. But the mental health dimension, depression, anxiety, emotional eating, trauma, binge eating, stigma, shapes so much of how people experience their health, their bodies, and their care.
Mental health isn't a nice to have in obesity management. It's a core part of the pillars of obesity treatment, and yet it may be an overlooked piece of the clinical puzzle.
To help us break this down, we're joined by someone who has helped shape the conversation in Canada and internationally, Dr. Sanjeev Sockalingam, a psychiatrist, researcher, and co-author of the mental health chapter of the Canadian Adult Obesity Clinical Practice Guidelines.
Dr. Sockalingam, welcome to the show.
Thank you for having me. Excited to be here.
So let's start with that big picture. The clinical practice guidelines describe obesity as a chronic disease with biological, psychological, and social drivers. From your perspective, why is mental health such a central part of understanding obesity?
Well, I think Michelle stole my thunder already to say that it is critical to obesity care. And you know, it's interesting for me. I'm a psychiatrist, but also practice obesity medicine. And I came later to obesity medicine than I did to mental health. And I would say my own journey is a reflection on what my patients taught me along the way, which is, the mental health components. If you are in a mental health clinic, often are the first signs, perhaps, that someone may be struggling with metabolic dysfunction and could be living with obesity. And I'm using obesity, not just larger body, as I've listened to your podcast before, so I know where we started and where we are. But also really thinking about it from excess adiposity that leads to functional impairment and negative health outcomes, and one of those negative health outcomes could be mental health, right? I know there's a little controversy in that. I actually, in the field of obesity, speaking to people who are experts, some may say there is a relationship, but is obesity a cause of or driver for mental illness? And that to me has inspired my own professional career and development and advocacy because, when you hear it from people living with obesity, mental illness really can be some of the first signs someone presents with, right, into a clinic, whether you're a family doctor, nurse practitioner, or a specialist. Or it could be a complication from obesity where people have been untreated for obesity. And as a result of either weight bias, stigma, or biology, as we can talk about, mental illness might end up being one of the signs that you recognize later on that someone is having functional impairment in their life. And so to me, it's a no-brainer, but I'm still surprised in 2025. Mm-hmm. I still have to have this debate with some of my colleagues.
Wow. Now, I know from just the general people in my life and in my circle, professional, family, friends, depression and anxiety don't just occur with obesity, but they can shape motivation, coping, eating patterns, even someone's ability to go and access care, right? If you're dealing with depression and anxiety, maybe you could help the clinicians that are listening to the podcast to understand how these conditions interact with each other.
Absolutely. So, part of why it's so important to consider mental health, and I'll say mental health conditions or mental illness. Again, we should all have mental health, but some of us are struggling more.
Yeah.
And so we have a condition. I want to be distinct about that. But what I think, Michelle, you're talking about is, for example, anxiety and depression, and how does that interfere or play out for people in the course of managing and living with obesity. And I think if you think about depression, and we talk about clinical depression or major depressive disorder as being one of the most prevalent chronic diseases and parallels obesity, but also has high burden like obesity as well. That the hallmark of major depressive disorder is either a persistent depressed mood or a lack of interest or motivation, which are really the core features, but also has things like reduced energy, sleep disturbance, changes in appetite, and there are types of depression that can lead to overeating as part of the presentation as well. As well as continued impact on one's ability in their social, occupational, or other parts of their life. And so think about someone who might be presenting for obesity treatment or care and who may have had undiagnosed depression, which might be labeled as being part of living in a larger body, for example, and you're fatigued, so you should expect that. That's not a big deal. We can come back to stigma, maybe, as I'm sure, later on in this episode. But I think in that context, you can see how having decreased energy, sadness that might lead to isolation and difficulty wanting to reach out to people, fatigue that then compounds other health issues related to obesity, guilt related to that, and that vicious cycle on top of that as well, and guilt and shame. How that can be another layer on top of this that really compounds or worsens everything that someone living with obesity who might be struggling might encounter. And then think about any recommendation we want to kind of work with collaboratively with the patient, that if they're dealing with that and we don't address it, it's going to impact someone's ability to make some changes, stick to a treatment plan that we try to recommend because we've missed depression. And likewise for anxiety, one of the most common conditions we see is social anxiety, for example, in people living with obesity. And you can see the relationship with people who've had really bad experiences as a result of weight bias and stigma, that there's a no-brainer there that someone would have social anxiety in those situations. And you can think about then asking someone to go into groups for treatment or support groups or access care, how that might negatively impact someone and be a big barrier. And we might not even recognize that for someone as well. And so it's really, really important for us to think about this interplay between mental health conditions and obesity. And, it's not surprising that, for example, depression untreated results in difficulty with adherence to any treatment in so many chronic diseases. There's like uber evidence for that. And so I think with that it's hard to ignore that even if we have the best treatments available for obesity care, we miss depression in someone, in addition to the impacts on their quality of life, we're probably not doing a good job as a healthcare provider helping them to reach those outcomes, because it might be so hard to stick to those treatments. Yeah.
So well put, and all interconnected. So with how important it is from a screening standpoint, we hear a lot from clinicians that they don't actually feel confident screening for mental health concerns in a short visit. And I think a lot of them are familiar with sort of the implications of poorly treated mental health and chronic disease in general. What are a few simple evidence-informed ways for clinicians to start recognizing mental health factors that may be affecting someone's obesity management?
Sure. I'll step into that, but I'm going to get on my soapbox for just 1 second here. Just to say that, I just find it fascinating that there are parallels between mental health conditions and obesity, because what you just described, Roshan, is that healthcare providers worry about asking about mental health conditions because they don't want to open Pandora's box, and like I won't be able to put it back in. I only have 10 minutes. Um, but in reality, there's not enough psychiatrists or mental health specialists to provide mental health care. Most of it is done in primary care, and family doctors and nurse practitioners do an excellent job uh, with uh, with treatment. We all can improve, but do a pretty good job. So I think that's probably no excuse for us to open that up. And if we don't know, we can refer. But we can talk about practical ways people can start to discern. And some practical things are uh, for depression and anxiety, which are one of the two most common conditions that co-occur for people living with obesity. There are some pretty valid tools and accessible tools, and also tools that are built into electronic health records of all sorts. So, for example, a tool called the Patient Health Questionnaire 9 or PHQ 9, or the Generalized Anxiety Disorder 7 or GAD 7. These are really, you can boil them down to 2 item scales. And if you get a positive on those 2 items, then you can ask the remaining. So, really, what you're asking is 4 questions that you could give to a patient in a waiting room in your electronic health record to screen and then decide if you feel comfortable opening that Pandora's box and having a discussion about treatment or assessment and treatment, or that at least you acknowledge that there might be something there that you might want to get someone who you feel could explore that better than you as a healthcare provider. And so I would say those are some easy ones, but it may even start off with as you're asking about someone's journey with managing weight or obesity or whatever might be the reason someone is coming in to ask that question with a healthcare provider. I also ask about how someone's mental health and well-being has been through all those experiences, and that might open the door in a non-structured way of a checklist or a scale, because I do think for me, every single patient's journey is quite different, which is why I practice medicine. I just hearing a story and learning from a patient and the different ways that someone has gotten to my clinic or care setting or hospital is quite unique. And I think in doing so and asking about this emotional impacts, some of the factors that mental health factors that may have contributed at those times might give me insight into, one, some of their resilience and how they cope and manage, but two, how where there may be tipping points where those might have been signs of some early mental health conditions or struggles that require further exploration. So I would say the two are, you could use rating scales, or you can ask with a simple question about, how are they coping or managing, to open that, or how they coped at a certain time in their life, to really understand that emotional and mental health experience.
And I imagine this goes beyond symptoms. Things like hopelessness, worry about judgment, or feeling undeserving of care can play a role too. How can clinicians create that safe space for patients to feel safe naming these experiences?
Yeah, this is a tough one because we're asking clinicians to undo sometimes decades of um, challenges and unfortunate experiences, maybe even traumatic experiences that patients have experienced as a result of their healthcare journey or journeys as a whole. And so, um, I think about, as you mentioned, hope or lack of hope in those circumstances, difficulties, and feeling safe in these environments. Really, it is starting with just listening to someone's story and journey. And so this is really hard to do in our pressured
Yep.
healthcare environment. 10 minutes, 15 minutes,
15
20
minutes.
minutes, whatever you want to say. And, starting with, what brought you in today and how can I be helpful to you, right? You might unpack one of the major concerns. What we often say is kind of primary complaint in medicine. But I think it's to understand, tell me a little bit about, you know, how this has become a struggle for you, or why this is important for you, or trying to understand and explore that curiosity. And I would say compassionate curiosity is really key in asking those questions to understand a patient's experience. And even taking 2 minutes to understand someone's experience can start to say, hey, I'm not being told about recommendations. I'm not getting given judgments. I am creating there's some trust that's creating in our relationship. So I think that's one, and it seems like basic, just listening and being curious as being a way to undo some of this. I would say from a mental health perspective, if someone is coming in for obesity care, and so I work in two settings, one that's primary mental health care and one that's primary obesity management care. And if someone is coming into that setting, I often create that trust in an obesity care setting through understanding, why they are coming in to seek treatment for obesity, and it usually could be weight loss if people present with that, or they often talk about losing weight as the first thing because that's what they've been told by somebody. And then I try to understand things that I know you've likely talked about in previous episodes, which is about understanding why that's important to them to lose weight. What will it enable them to do in their life? And that's when we start to get into relationships. Like I want to be around for my children. I want to be able to, travel, do things with my family. I want to prevent health outcomes because I've lost someone in my life my family member with significant health outcomes. And so all of these components can lead into insights of understanding. And then it allows me to do a little education early on to say, in addition to hearing a bit about your history, in terms of treatments that you've had, your health, your physical health conditions, I often do a little education that, it's not uncommon for people who are, struggling with weight and living with obesity to have challenges with their emotions and mental health at different times in their life. And for me, that when I say that, I say, I'm going to just ask you a little bit about whether or not you've ever struggled. And I screen for a few things like, depression. Have you had times and changes in your mood, like persistent low mood or lack of interest? And tell me a little bit about that, or anxiety in that context. I think those are some ways in which you could weave that into an assessment. And if someone were to say, yes, I only have 3 minutes left, I would say this is really important for us to explore. And we've talked about a few things today, but do you mind if we come back for the next appointment to really pick up on that thread? And right. And I think it would be pretty easy for me to be on this podcast and say you should be assessing and treating all mental health conditions within one visit. No one has the luxury of that unless you're a psychiatrist, and even then, at best, you might be doing a little the tip of the iceberg. And so I think this is really a longitudinal assessment and process. I will say there's an interesting one too about the fact of eating disorders and eating abnormalities, because when we think about mental health conditions, we do have diagnoses for types of eating disorders like binge eating disorder, which is a clinical condition and has strict criteria. It's not the term binge eating, which we use all the time, which actually is not clinical in any way. But binge eating disorder is something, again, occurs at higher rates in people living with obesity, but not everyone with obesity has binge eating disorder. But we should screen for it because there are treatments available, and whether or not we can offer those treatments independently or as part of some of the obesity treatment interventions, I think those are important to us to recognize and measure and help with. And it might even validate people's experiences in that they were struggling with this and never knew that they were struggling with this as well.
Yeah. I love that. The simplicity of what you said of
Mhm.
listen and be curious.
Yeah.
I don't know which one comes first. Maybe be curious first and then actually listen to the
There you go.
response. But, everyone can do that. All human beings can do that, whether you're a health professional or not. So I love that advice. I'm going to shift things a little bit in the fact that I'm going to tell you something that I have been known to say quite often. And this, although it'd be lovely to have this podcast all about me and everyone could just talk about me, that would be lovely. But it's something that I quite often hear from a lot of people,
Yeah.
right? And the question is, I know what to do, right? I just can't do it consistently. And that spirals into what's wrong with me. And I feel ashamed and I feel frustrated. And I'm a reasonable person in the rest of my life, right? Like I raise children, I have a job, I volunteer in my community, and yet I can't do this. And my question is, from a mental health lens, what is going on there and how can we help patients deal with that question and those frustrations?
That's a really good question and been an area of my research focus for a while, because a lot of what you just mentioned, Michelle, is that those spiraling thought processes. So I would say I sometimes use the analogy of the emotional salad spinner, where you are. Um, it's a term I use with my patients, and it seems to resonate because you get stuck in the salad spinner and you're spinning around and around with all these thoughts. Uh, and so, for those of you who are listening who don't know what salad spinners are, then you're much younger than I am.
Because that resonates with me, and I might actually use that. I really like that.
but it is an insight into kind of validating that experience, because those kinds of thoughts, it's like something's wrong with me, I'm not doing enough, comes from what we call some of the thought processes that are conditioned in us or learnt throughout our lives, right? And there is an intervention that many healthcare providers are familiar with, cognitive behavioral therapy, or CBT, that is founded on this premise that we all have life experiences that shape our thinking, or automatic or thoughts or thought traps that we develop, that are become so ingrained that we don't even notice them anymore. We just assume they're truths about ourselves. Um, and so you can imagine, and I know this from all the patients who've taught me through our research studies and clinical interventions, that having experiences in early childhood or late childhood where people who've been struggling with obesity but not had offered any help or had an outlet for this, who have been enduring bullying, shame, maybe parents, maybe loved ones, maybe friends, who've made comments that have reinforced that they're not good enough, they're different, and they're inferior. We see it in the data and how people are paid and salary for people who are living with obesity and those who are not. So it plays out in very concrete ways, but in the emotional ways, it really ingrains kind of that inner narrative that, wait a second, maybe everyone is telling me this and this is true about myself. And in those formative years and those experiences, it can lead to planting a really destructive seed of, like, I'm not good enough, right? I'm not deserving of this. And so every time an individual has been told, you gotta eat less, move more, and we know it doesn't work, but we've done it for so many years. It was my first research study, and I cringe every time I think about what I tried to do in my first research study. Um, that I think we are then feeding that seed and that growth, because you're setting someone up for failure, and it just reinforces it. The filters get on. We continue to get these automatic thoughts, and it becomes this. The inner narrative becomes the truth to an individual. And I think where we as providers can start to do this, not everyone needs to be a cognitive behavioral therapist or a CBT expert, but even, and I know many of my colleagues have talked about this in our Obesity Canada network, for example, about even just providing awareness and education or a language to a patient that this is what happened, right? These are the inner thoughts, making them explicit so that one can now notice them and be aware of them. And the other saying that my patients love to hate, what I say is awareness is a curse, because now you know, now we got to do something together about it, right? Um, so again, we become aware of this. And so if you're seeing someone repeatedly, and I've had patients then say to me, you know, I tried this out, Dr. S, because no one can pronounce my last name, and um, they and it's not working. And you know what? Uh, I don't think did it well, or I did it right, or this treatment is not working for me. I'm like the only one who's not responding to this treatment. Is something wrong with me? And then I go, aha, remember when we talked about thought traps, those little thoughts? Do you think this is something along those lines? And then we notice, we have a little giggle together, maybe that yes, all right, maybe I'm getting into a thought trap here, right? And then we start to look at, like, how many people, sometimes people don't respond to treatment one, but we have lots of treatments available and we can work through this together. And so we try to reframe that as from taking it as self-blame or one's own failing or lack of willpower, to us working together collaboratively. And this is a treatment that is there to work for you. Right.
Thank you. The mental health chapter describes a spectrum of eating-related concerns, from emotional eating to binge eating disorder, and the controversial but increasingly researched concept of food addiction. At a high level, how should clinicians think about these patterns without pathologizing normal human behavior?
So we all have to eat to survive.
Yeah.
So I think that's the first thing, right? I think we think about a spectrum of what we call kind of homeostatic eating, or eating based on hunger, for our bodies telling us that we need nutrition, right? And we have cues for survival for that. And then we can move along the continuum to things like loss of control over eating, right? Which is not a diagnosis, but that might be a bit more impulsive in nature. And, part of that can be thought of our brain neurobiology, and that, some of our reward pathways might be more sensitized to predispose us to loss of control over eating. Everyone has loss of control over eating. It's not an abnormal thing, but some people may have it more, right? And then we can think along that spectrum of getting into more functional impairment and distress, like binge eating disorder. And binge eating disorder is, a minimum of once a week, but can be much more frequent, of loss of control or eating a large amount of food over a short period of time, but also things like feeling ashamed or guilty about it afterwards, feeling distressed by it, doing it in secret because we feel ashamed by it, and then feeling, that it's starting to impact your lives, whether that's psychologically or interpersonally, for example, or in other domains of our functioning. And that is a diagnosis of binge eating disorder, and that's, again, some of our usual kind of pathways going that are a bit aberrant, in the sense of having abnormalities in how they're working. And then we go to the controversial topic of food addiction. And food addiction is not a psychiatric diagnosis, right? Although some people are advocating for it in reality. I will just disclose where I stand on this, because I think everyone should know where, when they're speaking about it, where they stand, is that I believe it's a set of symptoms that maybe might represent more compulsive type of eating patterns, but not its own clinical diagnosis or entity. And I'll say why. I say food addiction comes from this notion that if we have an environment filled with foods that are high calorically dense, that and research that shows that, from animal models from decades ago, that if you have this dense food and you compare it to the response of cocaine, and again, these were not in humans, these were in rats, that you would see the same types of reward pathways lighting up when you look at rat brains. And this has been shown in different animal models and replicated. I think we would all agree that, these kinds of foods do have that reward potential, that kind of abuse potential to it. I think the differences are how I started, that we all have to eat
Yes.
food, right? We all don't need cocaine
This is it.
on a daily basis, right? Some might argue with me, but we all don't. We all don't need cocaine and it's definitely not built into our day-to-day structure of our lives, right? And so food addiction to me is the compulsion, because what the diagnosis is, it's the Yale Food Addiction Scale. It's got its second edition now. And what they did is they took the diagnostic criteria for substance use disorders like addiction and mapped them on and substituted the substance with food. So, like, do you, consume a food in a way that you need more of it to kind of feel a certain way? Do you almost have withdrawals from it as well? Do you, seek food all the time and think about it all the time? All these kinds of things that are related to substance use criteria. And I think it is an interesting entity that it picks up more severe compulsive type of food, consumption of food. I'm not sure it's its own clinical diagnosis. And in the research we've done, even in Toronto, we found a high overlap with binge eating disorder, for example. Not to say that they were always 100%, but there's a high overlap. And I feel like it is a marker for um, a lot of different eating disturbances that we see in the context of treating obesity. And so, as a result of that, I don't know if it makes sense to create another diagnostic entity to confuse things when we already have a few diagnostic and other categories to actually quantify disorder type of eating in the context of obesity. So I'm not a huge proponent of it, but I think some people, I have patients who say, I'm addicted to food, I'm a food addict. And they would have found the Yale Food Addiction Scale and filled it out. And sometimes I've had a few that even brought it in and said, look, I have this diagnosis. And I said to you, I'm full disclosure, I can't diagnose it because it's not in my diagnostic criteria right now. Um, and I actually believe it's a sign of, I don't think it's its own clinical entity, but I hear that you're struggling with it and it's something that you're experiencing. So let's work with that. If you want to call it food addiction,
Exactly.
call it food addiction, and let's work together to figure out how I can help you deal with that.
Precisely.
So to me, it's the label. If it's helpful for someone to engage them in care, I'm happy to use it. I'm not going to put it down in my
Exactly.
diagnostic diagnosis in my note, um, but I will use my patient's language to describe
Yep.
what they're experiencing.
Agreed.
Yeah, I love that you're willing to use the patient's language, because quite often, most patients didn't go to med school, right?
Yes.
So we're using the words to explain things that we have. And so when a clinician says, no, let me tell you, that is not in the DSM. We are not going to talk about that. I don't care if that's your frame of reference or not. Like, it's not accurate. Immediately, I'm like, okay, I can see where this power dynamic is,
Yep.
and I'm going to sit down, shut up, and not say anything. And maybe listen to you, maybe not listen to you,
Yeah.
right? Because we've just ended, it's no longer a conversation. This is a lecture now, right? So I just wanted to say how much I loved that you're willing to start where the patient's thinking is and move into where your medical knowledge knows where you can go from that. And I love that. Thank you. I guess a lot of people living with obesity, as we've talked about before, have internalized the idea that their eating behavior reflects who they are, right? What they eat is what and how they eat it is who they are. And if you're living with obesity, clearly it's a personal failure in this. And I'm just wondering, to follow up on your last comments, how do you frame these patterns in a way that reduces the shame and helps the patient understand what's actually happening and move forward from that point?
Yeah, I mean, that is a tough one in the sense that, again, these have been so ingrained for so long for many people before they come to see me. And again, I start with listening to their story and their journey as well. And in many of the stories, and I'll take the context of where I work in a obesity center, many of the patients talk about so many things that they've tried and pursued to try to um, address obesity. Sometimes recommended on their own through their own research and in own means. And so, when we're talking about feeling like a failure or feeling like they failed from this, and how do we kind of help and correct and support some of that, I start end every kind of first assessment with the fact that I try to summarize what I've heard about their story towards the end. That usually it's along these lines, but it is very personalized to the patient in front of me. But I would say something along the lines of, um, you know, I've just heard you say to me, and I'm just going to check out that I understand your journey and where you're at. But I heard that you've been through a lot over the course of your life trying to address your health. You've sought so much help, and it's been really a struggle. You've tried numerous things and actually stuck to them for a period of time, and they didn't work for you. Not that you didn't do enough work; they didn't work for you. They didn't seem to work for you. But you've really shown tremendous resilience in how you've gotten here today. Because despite all that, you're here today trying to better your life. And it's usually for whatever they've told me is the reason, besides weight, that has led them to seek treatment. And so, and I just want to reflect that back to you, that you've shown a great strength and perseverance. And I'd like to help work with you to try to address this and try to help you achieve the goal that you identified. So for me, that's a reframe of, I've heard what they've said, and it may have been presented as failures, and they may have been told in the past those are all failures, and they haven't done enough. That those are now, what I hear underneath all that is someone who's really resilient, because they've really gone through all these treatments. They've done the searches on their own. They've been told things that are inaccurate, and they're still here in front of me trying to seek help. And to me, like, I hope that's one episode of a corrective experience that might be able to be an opportunity to work together. Does it work all the time? I don't know, because maybe the patients never come back, are the ones who are really upset with me. Uh, but I found, I've asked patients, like, how's that felt, like, maybe after working with them for a bit of time,
Right.
and many people have said, like I really, it was a bit jarring to me that you said I was resilient, actually.
Yeah,
And
I'm not
really,
even your patient, and I'm like, oh, that's such a lovely thing to hear.
Yeah. So we'll get back to our conversation in a moment, but first we want to tell you, the listener, about something big coming up next year. The Canadian Obesity Summit in 2026 is happening March 25th to 29th in Montreal. This is Obesity Canada's flagship scientific congress on obesity, bringing together researchers, healthcare professionals, and policy leaders from across the country and around the world. Sanjeev, you might be going to that. I'm not entirely
I
sure,
may be
but
there. I
maybe
may
maybe just for a day or two. It's 5 days of learning, collaboration, and community, all centered on this year's theme: obesity across the lifespan, connecting research to real world care. Registration is open and tickets are already selling fast. Learn more and secure your spot at the link in the show notes or by scanning the QR code on screen if you're watching on YouTube.
It's time now for our bias break, which is our moment in the podcast to reflect on how weight bias can shape clinical decisions, often without anyone even realizing what's happening. Stigma shows up in how we talk about obesity and mental health. They do have those two things in common, right?
Yes.
um, People are often told their depression or anxiety will get better if they just lose weight, which can feel like really dismissive, right? And so invalidating, right?
This is
Um,
all too common. From your perspective, Sanjeev, where do you see weight-related mental health bias show up most often, and how does it affect the patient experience?
I'm going to give you maybe two examples of where I think it shows up. I'll start with one we haven't talked about, maybe, is in mental health settings where my colleagues, psychiatrists, or other mental health professionals who are really focused on mental health um, often miss or feel it's taboo to talk about obesity. Um, and so, in my other clinical context, working in mental health settings, there are people who we encounter every day who are dealing with depression, anxiety, or more severe types of mental illness, who we as, and I'm going to say speak for psychiatrists here, we as psychiatrists, but also family doctors as well, yeah, treat both with psychological or medications, but focusing on medications, who we sometimes worsen obesity or cause obesity in our patients, and yet feel that someone should exercise and go to see a dietitian as a result of the intervention, because we have, recognize there's these risks with some of our treatments, or also before treatments, because mental illness inherently increases your risk of developing obesity. And I have many colleagues who have recommended, like, you should go for a walk, you should start exercising, you should start uh, going to a dietitian, improving your nutrition. There are billions of, or maybe not billions, but hundreds of millions of research dollars that are poured in lifestyle interventions alone to that are focused on eating better and exercising when people develop obesity after psychiatric treatment. And is, again, not to say that these things are not important for mental health and well-being. Um, However, they're not the solution for treating obesity. And so, I've often, when I've spoken to colleagues, said, I think it's, given that patients inherently have an increased risk just by living within mental illness to have develop obesity, we're using treatments that might increase those risks or even have new onset kind of obesity. And as a result of that, isn't it our responsibility to actually learn to treat obesity, especially because we are often following many of these patients for a period of time as well? So to me, that's where stigma plays out, is that people think it's someone else's responsibility, or it's uncomfortable, or um, or we bring our bias of diet and exercise as the sole solution for everybody that we're dealing with. So that's one component to it. I would say the other is what you talked about, which is many times when I'm seeing someone who's seeking obesity treatment, there are times people have been undiagnosed for decades with post-traumatic stress disorder, depression, anxiety, um, binge eating disorder, for example. And all of those things are there because of kind of diagnostic overshadowing. You see someone who's struggling with their weight, they've developed obesity, they're starting to develop health conditions, and clinicians are attributing this to the mood issues, anxiety. These are all related. All be better if you just lost weight, right? It's interesting. There's these two polar kind of opposites of the spectrum here, where we really are struggling to do justice and serve patients where they're at and how they enter the system in terms of obesity care and mental health. So I struggle with that, but I'm on a campaign if you want to join me to try to change that, especially in psychiatrists too. So I'll take as many people as we can to try to change that.
So I think a lot of these themes really highlight how much mental health and the way we talk about it shapes a person's experience with obesity care. And it also sets the stage for something many clinicians and patients grapple with, how treatment decisions intersect with emotions, cravings, coping, and the psychological side of obesity.
Exactly. Preaching to the choir. And of course, that brings us to medication. For many people, starting an obesity medication doesn't just change their appetite or the weight, it can shift their relationship with food, their confidence, also their expectations of what treatment should feel like. Um, Patients sometimes ask whether medications can also help with cravings and emotional eating. We've got we talked about the salad spinner before. This might be the salad, right? How do you help people understand which changes come from the medication and which require additional psychological support?
So that's an interesting and and it's a very common clinical question when people are having. I use the term kind of disordered eating in the context of obesity, right? So all of these things that could be diagnoses or descriptors of disordered eating. And so um, we know obesity medications and their evolution have been targeting disordered eating because we know that they work on appetite and eating behaviors through the neurobiology of the brain, right? And the different pathways from kind of homeostatic and our hypothalamus, but also our reward pathways or mesolimbic system. And so if we think about that, uh, and I'm not going to geek out on neurobiology here, but if we bring it back to kind of really practical kind of patient care here, uh, I think that obesity medications have been shown. It's just not me. It's what we have in the literature to impact disordered eating as a whole in a certain way. So some people will talk about craving reduction, and there's many studies for different agents that show reductions in cravings. With some of the obesity medications, maybe having greater evidence than others. And that is again through those pathways in the brain, right? We also know that these medications can start to, and I'll go now from a scientific term to what patients describe, which is kind of reduce the food noise or the salience of some of food, right, for people, right? And that in itself can have impacts on not just cravings, but also, loss of control over eating, emotional eating, and all of these things as well. Where we haven't, so my answer there is, in general, there are probably things that obesity medications can help with for disordered eating, and it'll be different for different patients and how they present as well. I will say where we don't have conclusive evidence is when we get into things like binge eating disorder, for example, clinical diagnosis. And again, I think we're moving across that spectrum we talked about earlier of more severe types of eating patterns or disordered eating. We have some studies out there for different obesity medications that have been done independent of industry, actually. There were some great studies done for one of the obesity medications called naltrexone bupropion, which is a combination kind of treatment for obesity. And it was done out of Yale without industry sponsorship. It was an independent trial. And they looked at behavior therapy, so like a form of cognitive behavior therapy alone, medications alone, and then combination of the two. And what they saw was that for binge eating disorder, again, not general binge eating, that the kind of CBT or behavioral approach actually had a pretty strong component. Medications were okay compared to it, but the combination really helped as well, right, for this. And so what that says to me is, I don't think we're at the point where we can say with specificity that these medications target some of the more significant clinical eating disorder symptoms like binge eating disorder. But they can work in combination with some of the psychosocial kind of treatments that we provide and that are part of obesity management and one of our pillars as well. And so what does that mean clinically? So for me, if someone has, some mild to moderate binge eating, and they might be binge eating disorder, and they're seeking treatment with an obesity medication, and that's the reason why they came in, is for treatment of weight loss for health reasons, for example, then I would start with that as a treatment and monitor where their eating behaviors are changing. And in fact, what happens is some patients might have resolution and benefit of some of those symptoms because they're linked to so many other things. And that as we start to treat with these medications and as they start to target more receptors, we may end up getting benefits for some of those subclinical eating disorder symptoms, and as well as some of those mild binge eating disorder symptoms. But for some patients, we may need to add other treatments on top of that. And there's, one medication currently approved in Canada for binge eating disorder. There's not a lot. And that is lisdexamfetamine. But CBT works for binge eating disorder as well. And so to me, the answer is, if you have someone who is living with obesity, has a little bit of has some disorder eating, some emotional eating, maybe some mild binge eating, then maybe treating with an anti-obesity medication, seeing if it goes away, and if not, supplementing with psychological treatments or other medication treatments might be beneficial. Where we have to think more about combination is someone has depression, and they are having emotional eating, they might have night eating, they might have other kinds of symptoms, and they're living with obesity and they're seeking obesity treatment. In our guidelines, we talk about using CBT there as really bumping up the line and treating comorbidities like depression and anxiety, because CBT is actually useful for depression and anxiety too. So you might get multiple benefits. And then we should be targeting more of these things early on, because it'll be really hard, as I said earlier, if we, just start with the the obesity medication and then wait, and they're struggling with depression and anxiety. So I think it really depends on the complexity of how quickly you intervene with multiple treatment options, medication or non-medication.
So Understandably, for our listeners, a lot of this can feel complex for clinicians who don't actually have embedded mental health teams in their practice. If someone's practicing in a busy family medicine or internal medicine setting, what are some questions, like 1, 2, or 3 questions they can start asking tomorrow to bring mental health more fully into obesity care?
I think one one thing that people can do is thinking about if you are in primary care and treating someone for obesity, you could probably start with even just asking about their past history, because some people have actually had some contact with mental health, like if they've had mental health contact. I think even asking about does their mood and or anxiety impact their ability to um, their current quality of life in day to day. So you can inquire about mood changes or anxiety that might be impacting someone's day to day functioning, and this might be part of your functional inquiry as you're talking to screening for, other comorbidities. You can start asking about depression and anxiety and understanding if that's important for them to address as part of their treatment, and so thinking about how you might prioritize that. And I would say this is not something you might ask, but I do think those rating scales are quick screeners and easy to use. And again, it allows someone to actually review it really quickly because they're not long, to say, I noticed that you're having challenges with your mood, that you scored it, not so great here, or you're having anxiety, you're feeling on edge all the time. And so I think those might be starting points for just reviewing and saying, is this something you'd like to have help with as part of your obesity treatment and care? So to me, those are some really important kind of factors that you could use. I didn't mention one thing is that in the um, PHQ-9 and the GAD-7, there are some sleep indicators. And sleep, mental health, and obesity really are a triad. I talk about sleep being the psychiatric vital sign because it is in the criteria for many mental health conditions. And we know that, poor sleep and disrupted sleep is a risk factor for developing obesity as well, right? So just thinking about that in itself can be beneficial for both mental health condition treatments as well as obesity management as well. So again, this might be one of the things that comes up on your PHQ-9 that you could review with a patient that might help both conditions.
And I would recommend to our listeners to check out our podcast episode with Dr. Michael Mock. And I don't know the number exactly, but we had a great and spirited discussion about the importance of recognizing and screening for sleep-related issues.
Yeah. On the other side, for patients, especially those who are feeling dismissed or judged, what is the one message you want them to hear about the connection between mental health and obesity, and maybe even the next step, treatment of the two?
So one thing I would want them to know that is that there's help out there and hope. And I say that because, I think about mental health being where, or obesity being where mental health was, 20 years ago. And I think people are a bit more comfortable talking about mental illness, and the pandemic helped accelerate that as well. Still have stigma, but getting better. And I think we are trying to catch up with obesity in that field. And so when I say help and hope, is that I hope that people who are living with obesity might consider, doing a mental health check and thinking about, do they need help for their mental health conditions? Is some of what they heard today, if they're listening or reading about this, something that they'd be willing to kind of bring forward? Because the hope part is there are actually good treatments for many mental health conditions now that have good effect, both psychological and pharmacological. and other that would be alternative, like light therapy and exercise and all these other things. So I do think that um, that would be my take-home message for patients, is that make sure that where you're able to prioritize your own mental health as part of your obesity management journey.
Thank you so much. Dr. Sockalingam, thank you so much for helping us see how central mental health is to obesity management and how small changes in our conversations can reshape patient experience.
Before we sign off, a quick note to our listeners. This episode closes out season 1 of Scale Up Your Practice. But don't worry, we'll be back in 2026.
We're already planning season 2, and we're excited to bring you more conversations, more experts, and more ways to support compassionate, evidence-based obesity care. Thank you for spending the first season with us, for sharing your reflections, and for helping build this community.
If you found this conversation helpful, share it with a colleague or a team member, and don't forget to follow or subscribe so you're notified when our new episodes and our new season go live.
Until next time, stay curious, stay kind, and keep scaling up your practice. This podcast is intended for informational and educational purposes only and does not constitute medical advice. The content shared in this podcast should never be used as a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of a qualified healthcare professional with any questions you may have regarding your health or a medical condition. The information and treatments discussed in this podcast are based on Canadian guidelines and approved practices as of the time of recording. If you are listening from outside of Canada, please consult your local healthcare professional to ensure compliance with your region's medical standards, guidelines, and recommendations. The creators of this podcast disclaim all liability for any decisions or actions taken based on the content discussed. Listening to this podcast does not establish a professional or patient-client relationship.